Thank you for staying with NTV. My name is Gladys Gashanja and this is NTV Today, coming to you live from the Westfield Mall right here in Lavington, Nairobi. And we are here specifically because AAR is actually opening its 21st outpatient center. Now that ceremony will be coming to you later on in the program. For now, our conversation of the day, lifestyle diseases. Why are we having this conversation? Is because these diseases are quickly claiming too many Kenyans, and some of the reasons could be because people are not getting diagnosed on time, some are getting misdiagnosed, and of course at times there are loopholes within the health infrastructure. A lot more on this coming your way, and to help me have this conversation with me, I have Dr. Alex Mogere, who is a consultant physician with AAR. I have Dr. Joyce Sitonik, who is the head of clinical operations at AAR, and Ezekiel Libamira, who is a throat cancer survivor. Thank you for joining me. Now, I'll just start with a bit of a background here. Now, we're living at a time where Kenyans are very aware that there are lifestyle diseases and other diseases, and you'll hear questions of how does this look like? What can I do to ensure that I don't have it? And that's why this morning we would like to debunk some of those lifestyle conditions that are claiming so many Kenyans, and actually to look at statistics from the World Health Organization. It said the top killers worldwide of people are heart attacks and strokes, and of course cancers and diabetes kill 1 million more. So in Kenya, what is the status? Well, according to the 2018 economic survey, cancer is the third major cause of death in Kenya. That's why you'd understand why we have a cancer survivor to help us have this conversation. And I'll start with you, Ezekiel. When were you diagnosed with this condition?
Thank you for having me here. I was diagnosed with this specifically on March the 7th, 2009. So that's approximately 10 and a half years ago.
Mm-hmm. Yeah. And what came about? What symptoms did you have that probably took you to hospital?
Okay, very good question. I was having challenges with breathing, challenges with talking, and I kept having pain shifting. If I would be talking to somebody, they would keep asking, pardon me. So I decided to go and check with the ENT because it was suspected to be sinuses. Mm-hmm. When I visited the ENT, she told me this is congested nostrils and gave me some medicine and told me in 2 weeks it will clear. In 2 weeks, it got worse. And I continued struggling with painkillers. And within about 6 months, my friends and family told me, no, you better go for a second opinion. You don't go for a second opinion to the same doctor. So I had to go somewhere else. Yeah. And when I went for the second opinion, they did some tests on me. They asked me to go for a CT scan, which confirmed a tumor. And they said the tumor was in my nasal strip. That's how they described it. And then that's when I was asked to go for a biopsy test, which took place at the same ENT center. And after 1 week, that's when I got that if you like, call it gift. Mm-hmm. Yes, that's when I was given.
Of knowing what you were dealing with.
Of knowing what I was dealing with.
Okay, just listening to Ezekiel, Dr. Sitonik, I mean, the rate of misdiagnosis or just no diagnosis at all could be one of the factors that most people are succumbing to cancer, right?
Okay, yes, indeed. The first step with the journey in cancer is to actually get down to the diagnosis. Mm-hmm. And then not just a diagnosis, but the precise diagnosis. Yeah. I think we see quite a number of these kinds of stories. Yeah. And as you've had, the symptoms mimic common conditions. Yes. Typically, I have this recurrent headache. I have my stomach is not sitting quite right. My back keeps paining on and off. Initially, it just seems like a normal issue. Mm-hmm. But then the thing that makes the difference is that the timelines. Mm-hmm. If a symptom is lasting, say, more than a week, you've done the first line of treatment, mm-hmm. and it's not getting better, you should ideally then get the second opinion. Mm-hmm. And it is actually possible to go back to the first doctor and say, okay, Daktari, the first treatment you gave me has not made me any better. If anything, I've gotten worse. Because how we come to diagnosis as doctors is sort of like there's an algorithm that you follow.
Yeah.
If this is if this kind of treatment works, then fine, we got it. If it doesn't, then I probably need to think at what else could be happening with this patient, and thus then you move down the investigation ladder until you finally get to what you're dealing with.
Now, Dr. Mogeri, I'll take you back to an incident that happened on the 1st of July, where we lost the late former CEO of Safaricom, Bob Collymore, to AML, myeloid cancer. And one of the things that caught my eye is the fact that he was misdiagnosed. The first time he started showing the symptoms, as Dr. Sitonik is saying, fever and lethargy and such like things, it mimicked other conditions, and actually he was told at some point it was a vitamin D deficiency. Then along the road is when they found out he was dealing with AML. He was actually diagnosed 6 months later. Now, the layman might not know what they're dealing with, but clearly even from the practitioner's point of view, it's easy to miss something if you're not looking for it.
Yeah, thank you, Gladys. That's right. Because the problem with many of these malignancies, they come with various symptoms, and most of these symptoms, as Dr. Sitonik has said, mimic many other conditions. And one has to have an index of suspicion that is very high. For somebody with a headache, and if one is not very keen, one does not take a good history from the patient, does not do a proper physical examination, may end up missing a lot. When it comes to diagnosis, it is very important, especially when the patient comes to you, apart from listening to the history of the patient, that you look at that person as an entity. The story itself may not be enough. Sometimes as doctors, we're very quick to actually just go by what the patient says. Sometimes the patients actually are misleading. Just to give you as an example, some patients may come to you saying that they have a dizziness. Right?
Yeah.
Now, out there, many people associate dizziness with anemia, for example. Now, when you delve into that history further, you actually realize the dizziness they're talking about is something else. They may actually just be talking about a spin, which they use, and they use that name liberally, dizziness. Those are two different circumstances. So it is extremely important that the doctor listens to the patient and interrogates the history extremely well, and then now corroborate the history with proper examination. And now this is a head-to-toe examination. So, because for example, as you've just rightly said, AML is a condition that will come with different symptoms depending on the stage at which this patient presents to the doctor. And the symptoms are very non-specific. The patient may just come with fatigue. The patient may just come with pain in one region of the body. It may be a limb, it may be chest, it may be the leg, it may be a knee. The patient may easily succumb to simple infections, or they may get recurrent infections. Because you see, the problem with some of these conditions, or generally malignancies, is that they not only present as primary diseases in the site where they cause the problem, they can also spread to other areas. AML, which is a form of leukemia, basically is a problem that begins in the bone marrow. And then from the bone marrow, you may get leukemic cells infiltrating other organs. They can go to the spleen enlarges, can go to the liver enlarges, it can go to the bone, and the bone becomes tender. So when you examine, you may actually find that you actually pick some signs in this patient. Now, vitamin D deficiency, which unfortunately happens in a tropical country when we have all this sun, yes, may present occasionally with tiredness, malaise, and so on. So there is a possibility that it can be misdiagnosed. I need to say that when you corroborate a good history, physical examination, and combine that with good laboratory pathological findings, it's actually safe to say that it's very difficult to miss the diagnosis. So I think a proper physical examination, because I don't think we need to go outside of the country to actually make that diagnosis, to be honest.
It can be done
I've treated a couple of patients with AML. We have made the diagnosis here. So this is something that we can actually do right in the country here. So the only thing is that, as Dr. Sitonik said, if one is treated for a condition and it keeps on coming, think twice. There could be something one is missing. And I'm not saying doctors are perfect, because there are times when you may actually miss something just because you have a tunnel vision.
Yes.
And sometimes when the patient comes the second time, then it makes you actually think twice about it.
Okay.
And sometimes if you feel that you're not getting it, sending to another person for a second opinion doesn't mean that you're not clever.
A good doctor,
Right?
yes.
It doesn't mean that you're not a good doctor. So I
Yeah.
think we also need to learn the humility of actually sending our patients to our colleagues to just have a second look. So I think one of the things that probably we need to learn as doctors is also some form of humility, where we actually extend referrals, as also Ezekiel said.
Okay. Now, Ezekiel, Dr. Harry mentions that a good history is important in getting the proper diagnosis. And one of the histories, and I'm sure the doctor will ask you, do you have any cancer in your family? Do you have any cancer in your family, Ezekiel?
Good question. By the time I was diagnosed with the cancer report, there's only one person in the family who had previously been diagnosed with prostate cancer, and that's my father. And of course, having read the story of prostate cancer,
Yes.
we learned those days it was the largest killer for men above 50 in the US and Britain. So for us, you began by saying lifestyle disease.
Yes.
So for me, my father, having gotten the prostate cancer, he was in his advanced age. He was over 70 by that time. Now, as lay people, we knew that he never took any of the goodies in terms of the foods we ate. He never used sugar all his life. As soon as he retired, he began taking sugar. And I remember, for all my life living with Dad, there's not a single day did I ever see him go to hospital. But after he began using sugar, we got this report.
Now, when you were diagnosed and you knew about your father, were you surprised?
I didn't even think about it. I'll tell you the reason why I didn't think about that. First, let me go back to this second opinion that I went through. The doctor was very good. He was very good the way he handled me. And he told me that it is possible that you could have a tumor which might have other conditions within. However, he mentioned to me that from our history,
Yes.
80% of the patients who go for testing for cancer come back without cancer. I couldn't forget that day. I thumped my chest and I said, this man can't have cancer. Why? Because all my life, I had never stepped hospital for any treatment that can be considered serious, except for the common colds, like malaria.
So you were clearly your father's son. Never went to hospital.
Never, I had never. I was a healthy-looking guy, so to say.
Okay, now, Dr. Sitonik, the reason why I specifically asked that question is because the doctor can make the diagnosis, but the patient can live in denial and not get the proper treatment. So in this case, and I like the fact that you brought up prostate cancer, most men would probably not go for a diagnosis to get a proper diagnosis, or even when they get the diagnosis, probably stay away from proper treatment because of how they view having cancer or any illness whatsoever.
Gladys, that's a good question, and I thank you for that. And I also thank Ezekiel for, basically telling us about that part of his journey.
Yeah.
And cancer screening has been an area of focus for us at AAR Healthcare. And those barriers are quite real. The fear of going to get tested for cancer, I mean, what are the chances I'm going to get the cancer test positive? What do I do when that happens? And what we've tried to do is actually demystify that whole process, make also the whole experience of going to the hospital to get tested for cancer and other lifestyle diseases more bearable, with a pleasant setting, not so scary. which quite a number of people find it difficult to go to the hospital. They say, oh, just that smell makes me feel like things are really bad. Aside from that, then the tests have become more friendly. Like for men, we are now doing blood tests for prostate cancer. For quite a number of other cancer test screening, we are doing a simple blood prick and a needle prick, and you get your sample taken, and we can give you the results. Now, family history of illnesses, and not just cancer, but even things like diabetes and hypertension, is an important thing for anyone to want to know. We say knowledge is power. When you know what your risks are because of being in a particular family or having relatives who've gone through certain conditions, then your search is a bit more targeted in terms of these are things that I know I must keep checking regularly. Like for example, for men, if you've had your father or your brother, a first-degree relative, been diagnosed with prostate cancer, the risk for cancer is almost twice as high for you. So you need to get checked at least every year after the age of 44 for the prostate cancer. And we've actually seen that work out for some people, where now we are able to detect cancer much earlier than we would in the past, where we were waiting for people to get sick, and then now they come in and get tested. Also for women, if your primary relative has had, say, breast cancer or ovarian cancer, you need to get checked regularly to ensure that if it happens to you, then you catch it early. So it makes a huge difference when people talk about it. That's again another barrier. People, when they are diagnosed with cancer, it's the big family secret. In fact, even before you tell that information to your close relatives, your brothers and sisters, you've really tried to hide it. But when you hide, you're taking away a protective weapon from your relatives. If they know, then they know what to look out for.
Okay, now Dr. Mogere, we know the survival rate of cancer is very high, especially when it is actually caught early. And as we're still talking about prostate cancer, you will see that it claims a lot of men, not because it cannot be survived, it's because they took their time to get to hospital, the screening to start with, or even get the proper treatment for it. Myths are a big, big deal when it comes to men, but also that test when it comes to prostate, talking to a man, tell us about it and how it spooks most men.
I think first of all I need to mention that the health-seeking behavior of men is extremely different compared to female-seeking behavior, especially in this country. And this is for most conditions, even just simple things, just as a cold. Now, when you go into details such as prostate disease or what we call genitourinary system, for example, many people feel, or many men rather, feel that that intrudes into their privacy. And for them, that privacy is extremely important. And many of them are actually unwilling to even share it with any other third party, and that includes even their doctor. We have examples in our own families where we have had to see people late just because they never thought that they want to tell anybody about it. So when it is extremely debilitating, that is when now healthcare is sought. So I think it is extremely important. I always say that if we can actually take the liberty to take our vehicles for checkups every so often, and we are very particular that it cannot go beyond 5,000 kilometers.
For service, yes.
Yeah, for service, or 10,000 kilometers. Why would it be different for ourselves? Why would it? It's extremely alarming that we actually don't consider that very important. So I think it is important that as men, and even just generally speaking as people, that we actually just consider doing routine examinations with the doctor, because sometimes what you find is that the doctor just picks something that may not necessarily have been very significant to you. All right? Like you may find that for prostate, for example, the main thing is urinary symptoms. You're having hesitation as you pass urine. Okay, when you go there, you're standing for 2 minutes before the urine comes out. You're waking up many times at night. All right? So it just tells you that there could be something with the prostate. All right? Maybe getting tired easily. You may be having anemia. Anemia is one of the common features in patients with malignancies. So it may just be one of the what we call red herring, where we actually just pick a malignancy from it. And that also includes lymph nodes that are not supposed to be there in the first place. All right? You actually are walking around, you're okay, nothing seems to be okay. You go to a doctor, the doctor picks a lymph node that is not where it's supposed to be. It is larger than it should be. Then that gives a red herring. The doctor now takes that to the next step. So I think what I would like to encourage our viewers is that let's encourage ourselves to have routine visits to the doctor. Let's just not make it a habit of visiting the doctor when there is some pain somewhere.
Yes.
Because that's actually what happens. We only see doctors when there's a headache, when there's a pain, when there's a disturbing cough like I'm having today with a cold and things like that.
Yeah.
So I think that's what I would like to tell our viewers today.
Okay, now Ezekiel, you talked about that your father had changed his lifestyle after retirement, took sugars, then you probably now related it to the fact that he was diagnosed with cancer. In your case, what is different about your lifestyle? Do you think you can attribute this apart from the genetic connection?
If you heard me clearly, I mentioned I never had any serious health challenge.
Yes.
I think, like you say, the information that's shared in the media amongst the medics can have an effect on the patient, either positive or negative. Now, I remember the doctor, after pronouncing the long terminology, something carcinoma,
Which just means throat cancer.
and he gave me the paper and asked me to Google. Now, the word cancer is so scary. I had a chat earlier with my good friends Dr. Sitonik and Moged, and I said, people in Kenya fear cancer more than they fear car accidents. Many years ago, I remember there was a report that cancer, by the World Health Organization, that cancer is the leading killer in the world. The report said it kills more people than malaria, TB, and HIV combined.
Yes.
Now, when you hear cancer, you see death. And I said, this man is no exception. I actually saw death, but I had to start fighting it in the mind on the spot. But the point I wanted to bring here, this doctor, after giving me the report, he looks at me and he told me, stop smoking. I was so angry, but I didn't react. Why am I saying that? He never asked me
If you're a smoker.
if I'm a smoker. And this man, my age, I am nearer 60 than 50. I have never smoked in my life. I was so angry and said, how can you dare? But I thought and I said, perhaps it's because throat cancer is related to smoking amongst others. And I spared him. So I think it's important, where else we patients need to give the doctors the right information. The medics also need to be careful on how they handle the patient, especially when it comes to this so-called death-threatening sickness. And I went through that, and I wanted to make some small correction with your permission.
Yes.
You refer to me as a cancer
Survivor.
I was given maximum of 6 months to live. The medics didn't think I would make it. Nobody ever imagined, whether it was pastors, family members. And I said, after I was done, I coined myself as a cancer conqueror, because I conquered death. So I went above survival.
Okay. He's a cancer conqueror.
Yes.
Now, Dr. Sitodiki brings up something very, very important. I mean, when you're dealing with that patient, and cancer as it is scary for everyone, you need to be at least empathetic to what it is that they're facing and walk with them, not from a practitioner's point of view, but from a layman's point of view. And how best should that be done?
I think let's start with that first statement. Cancer is scary for everyone.
Yes.
And the doctor is just as human, especially if this is a doctor you've probably been seeing for a while. Delivering the cancer, it is cancer diagnosis, is one of the hardest things doctor has to do to their patient. And especially if we've been through this journey together, trying to figure out what's going on. It's heartbreaking also for us as doctors. So, but that being said, we are taking back that feedback about how we break down that information to the patient, how well we explain what it means in terms of the exact diagnosis, how their life will change, what their treatment plan will be going forward, survival rates. But as you can see, survival rates, there is a scientific guide as far as based on studies over time. We've seen if you discover a cancer at this stage, the survival rate is X amount of period. But human beings are also the most amazing creatures, I would say, because where the story did not look inspiring at the offset, we've seen people make tremendous turnaround in how the disease is progressing, respond very well to treatment, and overcome the diagnosis. But of course the chances get better the earlier you get diagnosed. There are sometimes unique factors within your body that affect how well you take a condition like that. Say, for example, if someone has so many other conditions going on at the same time in the body, then you have cancer coming on, the body usually finds it harder to fight it. But if you had been investing well in your body, eating well, keeping low weight, exercising regularly, your resilience tends to be higher. So unfortunately, even after taking care of yourself, sometimes maybe because of genetic issues, you still get a particular cancer, but it definitely gives you a better chance of overcoming it.
Okay, Dr. Mogari, I like what she mentions, the fact that if you're living a good lifestyle, it'll probably give you a better chance of survival. But Ezekiel also touched on the fact that the doctor thought he was a smoker. That's why he had throat cancer. I shared with Dr. Sitonik that I've lost 2 friends this year to pancreatic cancer. And every time I would break this news to my close friends, they would ask me, were they drinkers? Truth of the matter is, church ladies never touched alcohol, never smoked, or whatever else that would be attributed to pancreatic cancer. So the question here is, why are we facing cancers now more than ever, despite lifestyle and other circumstances surrounding it?
That's an important question, Gladys. And I think it is important to realize, or maybe before I even talk about the possible risk factors for cancer, what Ezekiel has said is extremely important in the sense that we do not need necessarily to place assumptions on a patient's diagnosis. Throat cancer, in majority of patients, is caused by exposure to tobacco. But that's not the only cause, all right? That's not the only cause. So if one is not versed with the possible risk factors for a condition, then they are easily going to ascribe that condition to that possible risk factor. And it's actually going to be annoying, as he says, that one actually makes an absolute assumption that that is actually the risk factor, yet it's possibly not. But at this point, it's important to mention this, even as I answer your question, that there are several risk factors that may be involved in causation of malignancies, okay? And then in broad categories, okay? We have what we call lifestyle causes, which we have talked about, and this includes tobacco use, alcohol abuse. Remember here I'm talking about alcohol abuse, because there are those people who take some alcohol and they may question whether just taking alcohol is also a risk factor. It's actually alcohol abuse. Now, the other thing is environmental exposure, right? So we have such things as exposure to such things as asbestos, we have some gasoline, we have some ether, which are just chemicals that can easily cause people to develop other forms of malignancies, radiation, and so on. Besides that, we also have infectious agents. Just like Dr. Sitonik said earlier, there are infectious conditions that can also result in malignancies. For example, cervical cancer in women is actually caused by exposure to human papillomavirus, what is referred to as HPV. We also have cancer of the liver, which is caused by which may be caused by hepatitis B, and so on and so forth. So once you look at a medical condition, you actually need to find out, could there have been an exposure, so that what I talked about earlier, talking about history, these are some of the things that you actually want to identify. But it is also important to mention at this point that many times you may not actually find any identifiable risk factor. All right, but that does not mean that there was no risk factor at all. I actually forgot to mention the genetic thing that he was talking about,
Yes.
which is also a very important risk factor.
factor.
All right, so you may find that the only thing one has is actually a genetic predisposition. But then the thing with us is that we actually do not have a family history beyond probably our brothers or our parents.
Yes.
All right, yet we
Yes.
have great grandfathers. We have in other settings we actually have people who have those records. But unfortunately here we do not have. Many times when I'm asking a patient whether they have a family history of ABC, and before I even ask or finish, they tell me no. And many times they're actually not certain. It is not possible,
Yeah.
especially since we don't have records. Family history is not just your parents, not just your sisters or brothers or aunties or uncles. So it's important to know that there could have been a great grandfather who had leukemia, for example, and unfortunately we do not know. So it remains a possible risk factor. So what a patient should say is
Yeah.
that we do not have any that is known. Okay, otherwise we could actually easily have some. Yeah. So the thing is, what is happening right now with frequency and incidence that seems to be going up is that definitely our lifestyle has changed.
Yes.
We have adopted a more Western lifestyle, and the exposures are much more. Many people back in the day would actually do things that involve them moving a lot, so physical inactivity was not a problem. Eating fast foods was never an issue. The exposure to salted and processed meals was not a problem. So right now we have extreme exposure, and the problem is this: if, for example, I invited people to my party, and I decided that since I'm a doctor, I actually just want my guests to actually have healthy meals. Okay, that may be the last party I am holding, because because
Yeah.
many people would prefer to have those foods.
Yeah.
Okay, they would love to have their roasted meat.
Yeah.
They would love to have their processed food somewhere. But if I put some yams there and some broccoli and some vegetable salads and put some, it's very unlikely people will find that amusing.
Yeah.
Yet I'm really thinking about their health. So we are also affected by our mindsets and attitudes. While we talk about it, even me as a doctor, as I talk about it, do I practice this in the house? Will I invite my guests for my son's birthday party and give my guests what I've just talked about? I'll probably balance. So what is happening right now is that, of course, we're having these high incidents. First, because of problems with the health-seeking behavior,
Yeah.
but then more importantly and generally speaking is our attitude. Right? So we actually just need to adopt an extremely bold attitude,
Yes.
where we don't think about other people. Think about yourself, think about your future, and I think that will be the basis of getting a proper health economy.
Okay, Ezekiel, now that we're talking about mind shift, a change of attitude, I mean, you've conquered cancer, it's now going to 10 years. What did you shift in terms of what you ate, in terms of your lifestyle? What drastically shifted for you to have 10 years to your life?
Maybe I didn't mention earlier, I wear many hats. And what part of what I do is I am a motivational coach.
Aha.
So that played a key role. Now, when I got the news, like I said earlier, the first thing I thought was
Death.
death. And I cannot say I'm religious. I am a committed Christian. So what I did, as soon as the report was given to me, that first thought came. The next thing I did, I began to pray. The doctor was talking to me, and I was praying. He didn't realize I was praying. And I remember the words, with due respect to all religions, the words in the scripture, the Bible, that says, "Owe no man anything except the gift of love." I began telling God, "You know that I owe Gladys 2 million. You know I owe Dr. Sidonic 500,000. You can't take me before I pay." I was talking to God like a friend. Secondly, I am blessed with 3 children, 2 sons and 1 daughter. And in my mind, I look at their picture and I say to myself, for these 3, I must live. And that helped me a lot. So I decided, now what do I do in the work of treatment? Now when you get cancer, and the doctors will agree with me, in the public arena, you get too many doctors. Don't go for chemo. Don't go for radio. I went through lots of that. And I'm listening to them, but they're not listening to me. They're in a hurry to give you that, don't drink milk, don't do this. But nobody is thinking, what are you going through? I was going through, like, the whole earth has fallen on me. I mentioned to the 2 colleagues earlier, I am a victim of the post-election violence. And I lost millions of money to post-election violence. Secondly, I am also a family values champion. Now here I am. I'm helping people to spice their marriages. Then in that moment, I had a family challenge. So I said to myself, what do I do specifically to make my children stand? And I decided I will do anything under the sun to help the children realize I'm going to make it. They, of course, the 2 older ones, they didn't tell me. It's 7 years later is when they confessed they believed that daddy was going to die. But when they saw me bouncing back, and every other friend, now, like, I've walked this journey now for 10 years. And people are more encouraged. They say, if this guy could make it. By the way, I didn't say this. I lost about 50 kilos. I listened to a doctor, an oncologist, who said, when you lose 20% of your weight suddenly, you're on the verge of death. When I calculated 50 kilos, I lost 42%, meaning I was technically dead. So I would meet Gladys. Hi, Gladys. And Gladys can't recognize me. I know colleagues who see me in the streets. They went to the office, they asked, what happened to Zach? And they told Zach has cancer. Now the stigma that we have to fight. She said, I thought Zach had HIV. So when I saw him, I ignored him. There are those who stigmatize and they say, I don't want this guy to die in my hands. So I went through all that, but I told myself, there are children here, and I had to do everything to make sure I must. And then, but remember, my first prayer, I talked to God, and I believe God was going to take me through. Of course, I went through the conventional treatment, but my mind kept telling me I must walk through it. And I thank God that I'm here today to share my story.
Excellent. Now, Dr. Sitoni, clearly you can see self-zeal has pushed him 10 years after a doctor had said 6 months would not go by before he actually met his death. Talk about the stigma and the attitudes of those that come through your doors in as far as cancer is concerned.
I can totally understand what Ezekiel is expressing here, because it is really the story of many people who are living with cancer, either just diagnosed or fighting it or have overcome it, like he has pointed out here. The first thing is fear, and you know, with the human psychology, fear manifests itself in so many different ways. For men, there's anger, and isolation, for example. Even for especially, like if you're taking a leadership role in either your family or in the society, you're angry, and people feel that this is a sign of weakness. How could this happen to me? Or you're angry with God. God, haven't you seen all I have done for your people.
Yeah.
I've been, there for my family. I have made this impact to the world. We've seen some of our, the people who we felt have made a lot of difference, even in our own country and even in the world, have cancer, and I can imagine some of the thoughts that they've had around that. Then there is the fear of death. I think in our African culture, death is still considered, a no-go zone in discussion, a no-go zone even as a possible outcome. Yet it is the reality of everyone that we must go one way or another. And all those fears then now change how the interaction even with the doctor happens. Like, doc, no, you're not sure. You need to, almost sometimes you get attacked for saying, okay, we think this could be cancer. And you can see the patient gets very angry towards you.
Yeah.
And of course, then that also makes further discussion a bit difficult at that point. And the other thing is, then the relatives have to realize what is the person is going through.
Yeah.
And one question we get a lot is, how do we help? So one way the relatives would imagine they can help is reading around it, and also asking their friends what they went through when they were diagnosed with cancer. Yet everyone's story is different. Remember what you were saying, that you were told don't drink milk, don't do that. It's possible that one relative or friend had been told, when you have this cancer, would suggest you need chemo, or no, that one chemo would not be ideal for you, you need radiotherapy. Then we take that and put it as the ideal plan for another person's case. Every person's case is unique, and that's how the doctor actually looks at you. What is the state of your health at the point of diagnosis? What is the stage? What are the current options available for treatment? Unique factors in your body, like if you have certain other illnesses, hypertension, diabetes, or you've survived a stroke, how well can you take up, or how well can you tolerate the treatment that shall be given to you? What subtype of cancer are we dealing with? Sometimes certain types of chemo works for a particular cancer, but it's not the ideal for another type of cancer. Even if they are all called breast cancer, it actually differs as down that route. Then there's the issue of palliative care.
Yeah.
That is something that is also largely ignored and as an option. And I think there's been a lot of work to also sensitize doctors about the importance of palliative care.
Yeah.
We have in nearly 80% of our counties, there's a palliative center set up through the public health system mostly, but also in the private healthcare system, we have a few palliative care centers, which basically works with the patient. There's the psychological counseling that they need to go through. There's the family therapy that also needs to happen. The family needs to be prepared for that angry person.
Yeah.
Erratic behaviors from time to time from the person suffering with the cancer. Then they treat pain. Honestly, my personal mantra is, in this day and age when we have thousands of pain medications, really nobody should be crying in the middle of the night, screaming because they are in pain because of cancer. That is not acceptable. And there are ways that we can do something about it. Other symptoms that come in also as you're getting treatment, like with the vomiting, the skin issues, lack of appetite, all those can be addressed. But we need to then create that environment where we can talk about more than just the specific diagnosis of cancer,
Yes.
and look at the broader aspect or impact to that patient's life.
I like how you are taking this conversation to that ending as far as health infrastructure is concerned. And I see your feedback coming to us on Twitter at Gladys_Gashanja at NTV Kenya. There's one here from G. Kaikai who says, as a country, we are doing too little on global action plan for the prevention and control of NCDs as proposed by the WHO. We are investing too little in our health facilities. Dr. Mogere, do you agree? And what needs to be done to help along with this scourge that we clearly are facing head on as a country?
Okay, thank you, Gladys. I agree with the thoughts of our viewer. We still have a long way to go. Like I said, besides the fact that we have problems with health-seeking behavior, as a country, I don't think we have the infrastructure that is adequate to actually address some of those conditions that we're facing, especially with regards to non-communicable diseases in general. First and foremost, for us to be able to make proper diagnosis, or even just have a high index of suspicion, we actually need to have the right people on the ground. So it is important that we actually get proper skills on the ground. So training actually has to be thought about. I'm a bit disappointed right now. That seems to be an issue that seems to be getting off a bit, because we are dealing with things coming all the way from the national government to the county government. And at the moment, I think there's still a bit of an issue that is happening there. So if we can be able to streamline that so that we're able to get not only the basic skills that we need, but also the specialists in different areas. Right now, for example, I believe there are many challenges, like doctors getting back to specialize. We still have something that's not streamlined on that. Yeah? We need to have as many as possible getting to specialist areas. And this needs to be happening more than ever in this day and age.
Yeah.
Because I don't think it is right for us to still talk about problems that we had 10 years ago. Because I think, in my view at the moment, we're actually slipping back in terms of adequacy of the necessary and the requisite skills. So that's one of the areas that we need to address. Besides that, we also need proper infrastructure that will support these skilled workers. For a pathologist, for example, who remains a key resource in management of patients with cancer, we actually need to have them. But actually, if we are to look at how many we have in the country, they're actually very few. And even if they're there, do they have the equipment? There are places that cannot even do just a simple hemogram, which is one of the most basic of the tests that actually is needed for basic diagnosis of many conditions, and that includes malignancies. So we actually need to have a proper thought. And just to finish off, I think it is important to say that the management of non-communicable diseases requires a multidisciplinary approach. So we actually need to involve many people, all right? Ezekiel here, as a survivor of cancer, will have many tales to give about this condition.
Yes.
These people need to be co-opted in the management of these conditions. They can actually tell us what is it that, as caregivers, for example, we have gone wrong. We actually need to co-opt that. We actually need to find out, did it take so long for him to actually eventually get chemotherapy or radiotherapy? And what were the challenges in between? So that when we get such kind of feedback, then we know which areas to step into.
Yeah.
I know, of course, like for cancer, there is a national cancer control strategy that is put in place. But we also need to hear it speaking loudly to everyone.
Yeah.
Quite a number of even healthcare givers do not even know about it. All right. So how do we get these people also to know about it? So that as we see, because you see, the thing is, it is one thing to sit in a hotel and come up with policies.
Yeah.
It's yet another to actually see these people in a clinic and actually talk about it. So if the people who are actually seeing these patients do not even understand it, we actually will not even execute that policy. So it's important that we actually get a coherent plan, a policy that actually works for everyone, rather than just having meetings and meetings. We actually have to have a clear plan and a path to follow in order for us to be able to do this. I believe there are people who can do this. We just need a strong mindset and actually the willpower to do it.
Very well said. We take our first short break on NTV Today. Remember, we're coming to you live from the Westfield Mall here in Lavington, where AAR will be officially opening the 21st Outpatient Center. That ceremony is coming to you live on NTV later on in the program. But for now, let's take a short break. When we come back, the conversation around lifestyle diseases continues, because it's not only cancer that Kenyans are facing. We've got, as we said, heart diseases, diabetes, and many others. And we'll be delving into that right after this break. Stay with us. You're staying with NTV Today. My name is Gladys Kashanda, and today we're coming to you live with Mall. at Lavington in Nairobi, and this is where AAR is opening officially its 21st outpatient center. Again, as I said, that ceremony will be coming to you live here on NTV, so do stay with us even as healthcare is brought closer to you. Now, still on set with me, Dr. Alex Mogere, who is a consulting physician with AAR, Dr. Joyce Itonik, head of clinical operations at AAR, and Ezekiel Libamira, who says he's a breast cancer, or rather throat cancer conqueror. Well, thank you for staying with me. Now, before we went to break, that is Dr. Mogere, was talking about the importance of investing in our health infrastructure to ensure that we support those that are living with cancer, especially even as we talk about lifestyle diseases. And having walked this talk for 10 years, maybe you can tell us some of the loopholes you found in the system and why you opted to get your treatment here as opposed to outside the country like most people would prefer.
Wow, good question. First of all, let me begin by saying I believe in Kenya. I love Kenya. Now, what maybe may have happened, I think the doctors have also alluded. People, when they get what you might call misdiagnosis, they blame it on the medics. And I'm not here to defend them. But if they didn't give the proper information, that can lead to misdiagnosis. And let me come back to the structures. You asked a question to Dr. Mogere earlier, and I want to also add something. I remember in 2009, there was only 4 hospitals in Kenya with radiotherapy machines. When I was sick, I was given a choice. Do I go to the more expensive hospitals? Or the oncologist asked me, or do I treat you at Kenyatta Hospital? And at that time, I didn't have enough medical facilities in terms of the cover to take me to the private hospital. So I gave her permission to treat me at Kenyatta National Hospital, but she said, I will treat you as a private patient. Meanwhile, there were people who kept shouting at me and telling me, don't take your treatment to Kenya. Go to India. Go to India. And like I said earlier, it's so important and never accepted. Listen to the patient. I said, this is time for me to look at what our facilities can do. And I must be honest with you, having gone through 33 chemotherapy sessions, 33, performed every day except weekends, and then the infamous chemotherapy. It helped me, even though I had to use a lot of other, the medics will call it complementary treatment. But what my disappointment, and I'm not going to get political, I remember during the time I was now getting into recovery, we had 2 cabinet ministers, both of them handling the health sector. We had a minister for medical services and we had a minister for health services. In the same year, each of them got cancer. One was prostate, the other one I can't remember what it was. Unfortunately, they did not take their treatment in Kenya. That makes people feel that these guys can't trust our doctors. Why should we? And that has an impact on the population. Number 2, with those few facilities, I remember if I would not have gone to Kenyatta as a private patient, I was to wait for 18 months to start radiotherapy. So I had to pay extra to start immediately. And then one more thing that I felt so disappointed, and Dr. Mogere alluded to say, it's not enough to have meetings after meetings. I remember checking, and the cancer was increasing. I checked the budget for the Kenya government, and they had allocated, the word is, only 300 million for cancer. At that time, a second-hand radiotherapy machine was costing 250 million. The country has only 4. The government is allocating only 300 million in the midst of increased I think we need to get our priorities. Secondly, I remember that time as well, we had only 6 oncologists. I could mention all their names.
Yeah.
I did all the research I could. And in the midst of increasing, I remember one moment they said we have around 75 people then who are dying per day. And I would imagine those are the ones being reported. There could be the others that
Yes.
are worse. Are we together?
Yeah.
So I'm thinking we all can work together. And this is not saying this because the doctors are here. We've had cases. Here I am. I didn't go out of the country.
Yeah.
Like I said earlier, I lost 50 kilos. Now, to be honest with you,
Yes.
I am trying to cut some more weight because I have bounced back. I will show you my pictures later.
Yeah.
So I think I'm saying that we can all team up together, thanks to AR, what they are doing here. This one, I could treat this as going to Mashinani, so that people don't have to go to the few places. Because by the way, at that time, all the oncologists then, maybe even now, were based only in Nairobi.
Yeah.
And now people have to come from all over.
Yeah.
Okay.
Yeah.
So that's why. One more thing I want to comment. 2 more things I want to comment. She talked about doctors may have a challenge in breaking the news. Let me say this. When I did the biopsy, it was done through my nose under what you call local anesthesia. And the doctor finished and told me, "You are my bravest patient." I actually got annoyed with him for the first time because I thought he was flattering me. But fast forward, when I came a week later, and he looks at me and he shouts, "Ah, my bravest patient!" That's when I believed. Are we together? That is when I believed that, oh. So I can imagine for him to break the news. I still remember he could look at my eyes. He was reading the report and he says, "Mr. Libamira, I have some not good news for you, and I have some bad news." He couldn't face me. So I agree with you. Sometimes it becomes difficult to break the news.
They're
And
also
lastly-
human.
Lastly,
Yeah.
in my 10 years of doing cancer advocacy, men, unfortunately men, I'm a man,
Yes.
but men don't want to talk about it. It is so painful. I know cases where men have cancer of one or another, majority is prostate. Even their families, their wives don't know. That I'm aware. I meet them, I talk to cancer patients, I go all over Africa, and I've seen that as a challenge. So I go and ask men, come, let a fellow man talk to you and give you encouragement. They will say, yes, we'll call people. And the next meeting, you find they're
They
not
won't
there.
be there.
Yeah.
Yeah. Now, Dr. Sitanik, I like the fact that he touches on the fact that we need to relook how we look at healthcare when it comes to especially getting help for cancer and what have you, but also, even as AR, you're bringing the healthcare closer to the people. And some of the facilities you're putting out there is, for example, it is easy for you to walk in and get your screening. Now, people need to understand that it's not too beyond them to get that screening, which is very vital in ensuring you get the right diagnosis. Speak on the same.
Okay. Thank you, Gladys and Ezekiel and Dr. Mogere for laying the background for what we are doing. One of the greatest barriers to access to healthcare is geography. How far is the healthcare facility from where I normally operate?
Yes.
That is one thing that AR Healthcare has tried to break that barrier by going closer to where our patients live or our clients, and setting up away from the central business district and closer home. And this, we have seen, has opened up a lot more opportunity for people to access healthcare. And what we have further done is we are not setting up basic healthcare units. We are setting up fully fledged outpatient centers which have their laboratory services fully established, that even in our outpatient center, say in Kitengela, we can actually do all the cancer screening that we need. We can offer at our Williamson Outpatient Center or the City Center Outpatient Center at Jekwa Towers. So every point of contact with our patients gives them the full opportunity to access the best possible care that we can offer, at that point. And also we have our doctors, our medical doctors, who then are fully trained and are able to help the patient understand the results and guide the treatment plan accordingly. We have referral protocols. If this is positive or this test result is too high, sent to the specialist. And I'm happy to say that Dr. Mogere here is one of our key specialists. The physician usually is a higher level of medical education and understanding than the general practitioner. And we would then send to the specialist, including the gynecologist for the female conditions, and they then guide the treatment plan even more by, say, prescribing the drugs or helping us drill down to more specifically which cancers we are dealing with. Yeah, so and we are happy to say that even here at Lavington, we've been well received by the people living in this area, and we assure them that they can also get these cancer checks amongst other tests, including tests for diabetes, tests for cholesterol. Kidney issues are also a major issue affecting quite a number of Kenyans. And these tests are designed to be affordable, so that then it can be accessible. Now, the cost of doing the checkup is less than 1% of what the cost of getting treated for cancer could possibly be. So we would have wished to give it free. Sometimes it's not possible. In some instances, we do medical camps where we even subsidize the test further, but it's not something that we can always say will be, that lowly priced. But even at the price that it is offered at, gives way more value than you could ever compare to when you are found to have the cancer at a late stage. And we know one of the reasons why universal healthcare is part of the Big Four agenda is because healthcare easily impoverishes Kenyans. And if the healthcare costs are not, or healthcare issues are not addressed comprehensively, then the economic growth that we are hoping to get as a country gets held back. Because anytime a family has achieved or made some money or have bought assets, it just takes one member of the family to get sick, say with diabetes, with kidney failure, or with cancer, and the entire assets of the family is wiped out. The investment you had made on that person to take them to school, to university, all those gains, free education, gets wiped out because of a health issue that can be addressed.
Okay, Dr. Mogere, as we're speaking about that, let's talk about preventative medicine, because, prevention is better than cure, definitely. And I like a question here coming from Zipporah on Twitter, who says, very educative forum, Gladys. Could the role of nutrition be touched on? Because it's very key in preventative and perhaps important in the management of cancer. Speak on the same.
All right, thank you for that. It's extremely important, of course, that our viewers understand what we had already alluded to earlier, and that it's actually possible for us to be able to get these kinds of conditions earlier if we do the right things. I'd like to say, especially with regard to cancers, that 5 to 10% of cancers are actually genetic. Now, 90 to 95% are actually related to what we eat and environmental factors. Now, these are largely modifiable. All right?
Yes.
So what we're trying to say is that it's actually within your ability to actually control the outcomes. So it's important that one gets to understand what to eat and what not to eat. It's important to understand that exposures to certain things are actually harmful. Therefore, they need to take deliberate steps in order to avoid them. Talking about nutrition just from a superficial perspective, when we look at certain cancers, for example, from literature in different places of the world, and we have all manner of literature, things that have already been put up in journals. For example, we have cases of stomach cancers that are largely attributable to, say, smoked fish. Right? Now, it has been done through epidemiological studies that We have high incidence, say, of stomach cancers in places where we have people eating smoked fish a lot. Iran, for example, is associated with high incidence of CA esophagus, or cancer of the esophagus, what now people would call throat cancer. But throat cancer, for many lay people, would include cancer of the larynx, okay, which is the voice box, and then cancer of the throat, which is the food pipe. So I'm talking about the food pipe, all right? So exposure to hot tea, for example, has been attributed to cancer of the esophagus, all right? Now, there are quite a number of poisons or toxic substances that also get through our alimentary canal, through our gut system. So it's also important that even as we do this, because we get exposed to so many things that we eat, things that we drink, it's also important to realize that if we do not, for example, have proper habits, and this includes even just evacuations, stool evacuations. We actually are supposed to do it as regularly as possible, because the more the stool stays in the colon or the rectum, the more there is exposure to toxins that may eventually change the lining of those canals. And usually cancers are largely, for most cancers, are largely defects that occur in the what we call epithelial lining of this pipes, whether it is the food pipe or any other. Okay? So it's important that, of course, one gets to have proper visits to healthcare providers in outpatient clinics and get to know which foods to avoid. Alcohol, for example, is a risk factor in many conditions. From what you were alluding to earlier, cancer of the pancreas, cancer of the stomach, and so on and so forth. We have other things. For example, there are people who report having problems with their tummy every time they have certain foods. All right? So many people will associate that with hyperacidity, which is usually the most common cause. Yeah? But quite often it is also important to take it a step higher and try and isolate other possibilities. That includes presence, say, of something we call Helicobacter pylori, which is a treatable condition. All right? So you need to go and see a doctor rather than getting into a chemist, popping in an antacid, or doing other things. Just get into a facility, get to see a doctor who will examine you and do the ask for relevant tests. That includes, for example, Helicobacter pylori, which is also associated to some degree with cancer of the stomach. So these are things that actually patients can also try and do and avoid some of these things.
Okay, Ezekiel, in your work of, advocacy as far as cancer is concerned, I mean, since you were diagnosed to date, the dynamics of cancer have also changed with time. And as we're talking about, lifestyle is one of the greatest impact. What people eat, what people engage in, and abuse of alcohol and other things. What have you seen along the way as you talk to different people from different areas?
I entirely agree with that. But the challenge, and I'll be honest with you, is the average Kenyan doesn't understand what is lifestyle. I'll be honest with you. We need to break them down and tell them lifestyle is what you just said. What you eat, how you cook in this home. Many people are not aware. So when you begin to talk to them and you begin to interrogate them, then they begin to give you their story, then they don't realize it's my lifestyle that has contributed to this. For example, I laughed. I don't know if you noticed when you talked about hot tea.
Yes.
I loved hot tea. Maybe it's a course.
Yeah.
I went together. So, it is very important that people are educated. Secondly, I want to tell my good friends, the medic, those words you use, the medical terms, try to break them down to a simple
layman language.
It took the oncologist who was willing me to the first radiotherapy. She's the one who told me, in a layman's language, the cancer you have is called throat cancer. Hadn't she told me, I would never have known to date. I would have been trying to struggle with those long names.
Yeah.
And of course, that helped me. Permit me to say, Dr. Sitonik said earlier, knowledge is power. And when she told me throat cancer, I did remember there was a rumor, and I'm going to use the word rumor at one time. There was a leading politician in Kenya who had throat cancer. And I remember the story, and I said, so and so had throat cancer? And I counted the number of years he was alive. I didn't care how high he was in the East African leadership. I told myself these words: he's alive, I am going to live. And that also helped
Helps you.
towards my journey to recovery.
Okay.
Yeah.
All right, Dr. Sitanik, I know you are passionate about wellness, and wellness actually is described as making a conscious decision by an individual to maintain good health. Now, most Kenyans do not do this. We normally end up taking care of ourselves when it's too late, when you're trying to reverse the effects of what it is that you did. Speak on the importance of investing in wellness on an individual level, and how in the long run it thwarts some of those economical impacts you're talking about that comes with the diseases.
Okay, yes. Wellness is a lifestyle. And as Ezekiel says, we need to break that down.
Yes.
Going also from what Dr. Mogere has mentioned, these are changes in different aspects of your life, be it diet, be it physical activity, also mentally, that you have to make a conscious decision to do. Now, we are also living in these ages where fads are the in thing.
Yeah.
So like, if everyone is blending juices, that's a thing for like a couple of months. If guys are going to the gym, say to do spin, it's in. We are doing it because it's in for that period of time. We need to make conscious decisions, but also for personal long-term reasons.
Yes.
Yeah. So why are you going to that gym? Is it because everyone is doing it, or have you understood the impact of regular physical activity to your body? Then the other thing is, when you make a personal decision about what you're doing for wellness, then you are able to find ways that you can implement it in your life that is easy for you to maintain over the long term. The benefits of these changes to your diet, to your physical activity, to your mental health, you get the most impact when you do it sustainably for a long time. Yeah, so it's not enough that for 3 weeks in the entire 2019 you went to the gym religiously. That
Yes.
does not give you any benefit.
You can't keep stock.
Yeah, and even the impact, we cannot tell you that that is going to change your life. But if 3 days out of every week in the year of 2019 you were able to get some reasonable exercise done, at least 30 minutes of serious exercise, that is good enough. Yeah, so if it's as simple as, and that's why I like the discussions that have also been going on, pushing our county governments and also our employers to provide health spaces. If it is construction of a road, create a walkway so that if I decide my form of exercise is to walk to work, then that ought to be enough, and it's practical because I have to go to work every day. So I can maintain that in at least 75% of the time this year I will get some exercise. So exercise again is also not limited to going to the gym, for example. Exercise is also as simple as where is the printer located in the office compared to where I sit. It's less use of the phone to talk to my colleagues and actually walking to their desk to talk to them or to give a query. It is not how many juices I take, but how many times out of the 10 or 3, let's say if you're taking 3 meals in a day and you have a week, that's 21 meals. How many times out of those 21 meals do I make a healthy decision? Yes. Unfortunately, we also want to set an attainable standards for ourselves. We want all our meals to be healthy. And Dr. I hope you can back me up on this. Sometimes you may indulge, but is how frequently do you do it and how much? Yeah. And so if at least say 70% of the time when you're eating, it is healthy,
Yeah.
then you've done something great. Or if today, or we can even break it down further to your daily goals. If today, out of the meals that you would have eaten, you made one good health choice and decided to drink water more than you normally do, applaud yourself for that. But sometimes we want to look at, until the day I have the big muscles, the lean tummy, and my BMI is at X and say is at 20 and you're currently at 30 or 40, you will never celebrate the small steps that you make. But every small step is a walk towards, the right direction, and we must applaud it and still try to incorporate these wellness things into our daily wellness, ideas into our daily life routines.
Okay.
Yeah.
Now, Dr. Mogeri, I'm sure you have more patients now that we're talking about lifestyle diseases that are walking through your door saying either cancer patients, diabetes, heart diseases, stroke. I mean, these are lifestyle conditions that are being seen more now than before, and all being contributed or attributed to lifestyle diseases, or rather change of lifestyle. From your perspective, where are we dropping the ball?
Like I said, when it comes to achieving what I would call a good global health, either from an individual perspective or from a bigger picture or a bigger perspective, we seem to have a situation where we have sort of left healthcare to be handled by certain individuals, and that is where we actually need to place emphasis, that it actually has to involve many people, because it is very unlikely that your old 70-year-old in the village will actually take herself to hospital if they do not have any pain. So it is important that we actually try and assist those who perhaps may not be able to access healthcare. And this, of course, is a challenge that we have in the low-income to middle-income countries, because first of all, even when we do promote this, we still are faced with big challenges, especially in the sort of what we call low socioeconomic status. Just to give as an example, if I see a patient who lives 200 kilometers from here, comes to see me for a particular condition, just because I'm the specialist in that area, it means I'll have to give this patient an appointment. And depending on how they are, this appointment could be in 2 weeks, 3 weeks, 1 month, or 2 months, or 3 months.
Yeah.
So assuming that I'm actually giving a 2-weekly review, it means a lot of things have to happen. One is that we need to have the resources for that to happen. It is simple to think about it, but when you actually go to the nitty-gritties, you realize that it takes a lot. Because first of all, there'll be somebody probably who needs to take care of this person.
Yeah.
It means that they lose their day off work that day to just take this person to hospital. And there will be money that will be needed. Probably they don't have that money, they'll have to borrow. So the economy is actually going to be messed up, both from the micro level and the macro level. So we definitely have a problem there. So when it comes to such situations, we definitely are going to get patients coming to the doctors at an advanced stage of disease, and at that point it may be too late. So it means that we actually have to devolve our specialist services and healthcare services to the people so that they're able to access it easily. So we still have a long way to go, but I believe with the real desire and the willpower to do it, we shall be able to do that. Of course, like I mentioned earlier, that if we do not have the right attitude, there's no way we... People just need to consider their health important. Let's not regret that this happened to us, yet we actually never gave it a proper thought. Just get the time to get to a doctor. Even if you put it as once a year or every 6 months that you're going to see a doctor, just for a checkup. Okay? Don't feel the pain of paying that 2,000, 3,000 shillings to see a doctor, just look at you, right? Because we're quick to actually pay 90,000 shillings to a mechanic to just soup up a vehicle that probably we do not even need. We need new tires, we need just to get the proper rims and things like that. Just use a small fraction of that to just see the doctor. So all I'm trying to say is this, that let's change our attitude and let's put the infrastructure, and I believe the indices will change. We'll actually have a better performing nation in terms of healthcare indices.
Okay. Now, Ezekiel, I'd like to pose a question to you. Just a few weeks back, the first bariatric surgery was done in Kenyatta National Hospital in a public setting. And I remember this guy saying he was like 176 kilograms. And this is a surgery of the intestines to just help him cut the weight that he had gained over time. Now, what was interesting is that the wife said she thought she was feeding her husband well and was being applauded for it by society. As he ballooned for her, she, patted herself on the back because she was doing a good job. Yet this man was living a very unhealthy lifestyle and was too heavy for his BMI was out of this world. Talk about the importance of those living around somebody, the support system. You know what you need for yourself. How much more is it important for those around you that are supporting you through recovery and treatment and management of a condition?
Very good question, Gladys. Let me tell you, the ones around you, they can make you live, they can kill you. How they treat you, how they handle you. Because they're the ones immediately next to you. How they talk to you, they may tell you, oh, you're doing well, or they may even be flattering you. Let me go back from your report of the guy who was 176 kilos.
Yes.
This man here was weighing 100 and almost 10 kilos.
Wow.
Everywhere I went, people would applaud me. They would call me Meshimiwa. They would call me Bishop. Every name. I would go places with guys higher in me in ranking in society. I would be given space and they would be... So people thought this guy is looking well. And then little did I realize. And remember earlier on I said I was healthy looking. That is a challenge that people don't seem to realize. And for that lady, there are many others who are like that. Because they think if my husband is looking thin,
Yeah.
Allow me to use a Swahili term, nitaonekana kama simlindi vizuri. Unashika. And for me, that was a plus. It is since then that I realized. By the way, at one time I went for a medical checkup at what do you call this place? General Accident House. And I decided to go for a checkup, which people don't go for. And this lady looked at my weight then. I was being 90 kilos plus. And she told me, you are obese. I was angry. Okay, I don't react, sorry.
Yeah.
I don't react. I was like, how can she tell me I'm obese? That's not a good word.
It's an insult.
It's an insult. Because I felt I was looking good. By the way, the thing I took care of myself, I wasn't having a tummy, but I was looking good. And I was happy for that. Now, after this challenge, I realize I need to maintain. The BMI she talks about is so important. For me, okay, to some extent, maybe being big helped me to absorb the shock of the cancer challenge, When I check myself, I'm told I should not be more than 70 kilos. I actually dropped, by the way. I dropped from about 110 kilos. I became 61 kilos. And now the society looks at you as this guy is not healthy. So that wholesome information is so important.
Yeah.
You spoke about nutrition.
Yes.
Allow me to talk to my good doctors here. Again, there's been a perception in the public that the doctors are against nutritional treatment. It's not for all, but you see, I don't blame the doctors as well, because now there are people all over also peddling the nutritional therapy, and then they end up telling the public, forget what the doctor tells you. So there's a clash there. But if they will dig and the public can get together and say, let's get together and find how can we approach this. You spoke about prevention is better than cure. If we approach that, then the doctors will do their job with less stress, I believe. They'll do it at night, and people will want to come back to you more and more. Because ideally, Gladys, the doctor's word is more powerful than the pastor.
Okay.
It's the word Daktari alisema. The doctor said. So what they see is so important.
Yeah.
Even the guys, when they're coming up with that support system, they'll end up saying, have you checked the doctor? Yeah, so it's very important we team up, you know.
Yeah.
And
All right, and now that Daktari's word is important, Dr. Sitonik, speak on the same.
Yeah, and thank you, because I was about to ask, I need to respond to that.
Yeah.
As doctors, we acknowledge and we really respect the impact or the role of nutrition on the health of our patients.
Yes.
And actually, like even at AAR, literally every day of the week, we have a nutrition clinic running in one outpatient center or the other. What we are saying is we need to have trained professionals in nutrition health advising our patients treatment plans from a nutritional perspective that we can stand by and that we know are not likely to adversely affect our patients. Because we have had instances where somebody gets off the treatment train, we lose them to the nutritionist in quotes. They are not applying any specific scientific treatment to this person. And then the patient comes back months later, way worse off than where we had left them at. What we are saying is and also to reiterate what Dr. Mogere said is, lifestyle diseases cannot be addressed by one particular clinician. It's a group multidisciplinary approach that wins best. Now, you've seen there's the nutrition aspect. There's a strong psychological aspect on what makes you decide to exercise, to avoid this food, not to eat much. How do you receive information about your weight? For example, it's usually a tough, conversation to have. To tell somebody you're overweight, you need to do something about your weight. We've actually had patients come in and say, okay, just nurse, please check my blood pressure and temperature. Today I don't want us to check weight because I don't want us to have that conversation about my weight is too much. Yeah, I know. And it's fine, but it's good then to know. Yeah? And to know in a way that you can do and you can get the advice that this is what you can do, this is what you can modify. Another thing that people are worried about when they visit even our nutritionist is now that nutritionist is going to tell me, don't eat this, don't eat that, don't eat, as in remove all the good things that make, food is adds color to life other than just keeping us alive. But the approach we are using at our AR outpatient centers and also with other professional nutritionists in the industry is we try to make the most of what is already available in your home. If what you get is say the omena and sweet potatoes, that is what is readily available. I'm not going to start telling you to you better eat white meat every day, chicken for protein. If your vegetables are the managus, is what is available in your environment, I'm not going to start telling you have to eat lettuce and cucumbers and eggplant for you to get the right nutrition. We will work with what you have. And again, we work with you. Fine, we actually have some of our patients, the nature of their job is such that they are traveling a lot. So then how do we give nutrition advice that works for them? You're not in control of the food that's available, but how do you make your food choices when you're traveling then? How do you make your food choices where you're in meetings every day and you're presented with these foods all the time? So we work with you, and it's not a bullet solution that fixes your weight or your diet issues. Within the next 3 weeks you would have dropped 20 kilos. That is not sustainable and actually is not healthy. We work with you. Gradual weight loss also gives your body and your psyche time to adapt to the changes in your diet over time. And we have now regular checkups, so now you come back and tell the nutritionist, this is our plan, but I realized this can't work because also when I eat too much of this, it makes me sick. So maybe what else can we do so that we still achieve the same outcome.
Okay, now, Dr. Mogere, just looking through the diabetes statistics, for example, there is a spike in juvenile diabetes and type 2 in this case, where a child is of a certain age and you wonder why they are dealing with diabetes. And when you go back to it, it is a lifestyle dictated to them by their caregivers or their parents. I'll give you a good example. You go to a restaurant, you'll ask for a healthy meal, but you'll assume because they're a child, they should have your chips and sausage. Speak on how important it is to own the lifestyle changes we're talking about right from that child, so that we also reverse this now culture that we're seeing younger and younger people succumbing to lifestyle diseases.
Thank you, Gladys. I think I'll need to do a correction. Younger people suffer from type 1 diabetes more,
Yes.
all right? While older patients get type 2.
But it is developed, right?
Yes.
Type 2.
Sorry?
But type 2 can be developed.
Yes, it can be developed in younger. Oh, I
Yeah.
get your question actually.
Yes.
Now I get your fears. So basically, you find that they tend to develop now what we used to get more in adults at a
Yes,
younger
at
age.
a younger age.
So I get you. So the thing is, when it comes to diabetes, diabetes has a manifestation that is triggered by a couple of things. Of course, there will be genetic factors, and then there will be autoimmune factors, and then now the lifestyle, which now includes poor dietary habits, with now amassing a weight that eventually causes problems, where we end up developing a condition that we call metabolic syndrome. And in this scenario, the problem is not just the poorer management of glucose or sugar in our systems. We end up having even other conditions, such as even hypertension amongst young people. And that is why, even as we speak right now, when we look at the incidence rates of hypertension, it is actually quite high among people that traditionally were not expected to actually have hypertension. So it is extremely important that even as one figures out what to give their children, that they do not necessarily think that by giving them the kind of food Dr. Sitonik is talking about here, it is actually not giving good care to their children. Because we tend to think that, in this day and age, we should only be seen in fast food places on a Sunday, giving calories to our kids. We all seem to know where the terrific Tuesdays are. I mean, we know the best bargains in town. So we seem to have a big... I think we need to actually think through this carefully and actually begin to impart this knowledge to the children right from the start. Because you can imagine, if you start teaching them about this, it means that even as they grow into their independence, what will happen is that they will know that this is what my parents showed me. This is actually right. It will be very difficult to get this. So as parents, we're actually contributing to this, because this is a generation that will actually now become even more problematic in future. I'm worried about when I'm older and an older doctor. I think the statistics will change. We'll have bigger issues, because right now, for example, if we look at it, almost 50% of adult Kenyans are hypertensive.
Yes.
We're actually saying almost every other second adult is hypertensive. Previously, according to a study that was done a couple of years back, pre-colonial era, we never had any hypertensive patient of a native Kenya, of African descent. So what does it tell you about what has happened? So many things have happened, and we are getting worse. So I think my summary to viewers who are parents out there, please love your children. And love does not just mean taking your children to fast food places. Take them to your grandmother so that they can have the best mokimo. Take them to your auntie so that they can have ndumas and guashes. Take them to places where they can have the best vegetables that are traditional, and that will be giving your child health and a better future, rather than starting to deal with complications later in life at the age of 30 or even sooner. So we have a lot of work on our hands. And let's just not blame the system. Let's also point the other finger to ourselves.
Very well said. Well, even as we wrap up this very vital conversation, Ezekiel, again, I say throat cancer conqueror, 10 years on, you're an advocate of the same. Your clarion call to Kenyans, as far as taking their own life into their own hands and ensuring that they live a fuller life just by cutting out some things that are not necessary, and most important, seeking medical help.
Most important, I love the last one, seeking medical help.
Yes.
I want to tell Kenyans, your health starts with you. And I also want to borrow what you said earlier. Prevention is better than cure. I'm working as a person who I escaped death, by inches, because I believed, like you who is listening, you are healthy, and then suddenly this happened. So if we are able to begin to address, it has been talked about by the two doctors, Dr. Sitanik and Dr. Mongere. Let's start looking at how we eat, what we eat, and at the end of it all, we have generations that we have to, who are looking to us. And as a parent, and as a person who also is involved in family values, children look more to what you do than what you say. And you just summed it up. You take them and begin to give them those goodies because it's fashionable. You are planting in them unseen health challenges in future. Yeah.
Very well said, Dr. Situnik. We have a citizenry that does not have a culture of walking into a hospital and getting tested for this and this. As much as we've done campaigns, for example, go for your when you're going for your vaccines and HPV, there's a vaccine for it. When you go for your pap smear, there's a lot of campaigns around it, but Kenyans still don't embrace it. Your clarion calling as far as embracing screening and testing of any kind.
I think the main message, and this has been said before and we'll continue saying it, is your healthcare provider is your partner in health. We are trying to make our systems more friendly, more accessible, more human. At AR, our tagline is as human as you. We train our staff to be more approachable. We encourage our doctors to have conversations with their patients so that then health does not become a scary experience that you avoid until absolutely necessary. So just like the way we choose a school to go to, a bank to bank with, a telephone service provider to go with, those are investments that you're building in terms of a relationship, so that there's a history, so that now you understand this is how it works. It's the same way you need to look for a healthcare provider to be your building your medical history, because then you have your health information in one place. Like for example, at AR, one thing we ensured we did is that the patient file remains the same. No matter where they go to see us in any of our branches, your information remains in one place. All that will be happening is that we'll be updating that same file so that later on, and again, it doesn't matter if today you're insured by this insurance, that insurance, and you have changed, now you're no longer insured, still the file remains the same. You can still access our centers, get the healthcare you need, and now it's not that a relationship that's starting from the beginning every time, because we know what your history has been like, we know the treatments we've done, we know even the baseline tests. If today we do a cancer screening and we find it's high, we know we probably did it a couple of years back. Let's see what the result looked like at that time, and then we can advise accordingly. So we are here, and we would be happy to work with anyone who is looking for a partner in health.
Okay, Dr. Mogere, we cannot ignore the burden of NCDs as a country. Your clarion call to healthcare stakeholders.
Thank you, Gladys. I think, like I said earlier, we have a lot of work to do. I think let's make sure that we actually use the little resources that we have fully. We need to utilize them every time to ensure that they not only have the energies on the ground, but they also have the resources to be able to do their work. So for us to be able to conquer this menace of non-communicable diseases, which is becoming a bigger issue, we actually need to put enough resources, and this means proper budgeting. We actually need to go by what the Abuja Declaration recommended. We need to have a better percentage, 15% of the national GDP. We need to have it there. Otherwise, this will just be something that we'll always be talking about in different fora. At the same time, we need to also be true to the spirit of Article 43, which talks about the right to healthcare to every individual. So let's make sure that we actually live according to the true spirit of that. So we need to ensure that our patients are well informed, that our healthcare providers are happy with doing their job. I don't think it is right for us to allow situations where we have people who are actually trained to take care of people finding alternatives in other fields. If you're trained as a doctor, I do not see why you should actually be in politics. In my view, you actually belong in medicine. Let it be better, let it be nice for that doctor in Kericho, in Turkana. Let him feel nice to actually work as a doctor there, so that he can actually concentrate rather than looking at being an MCA in the local area as part of a solution to some of his problems.
Okay, all right. Dr. Alex Mogere, who is a consultant physician with AAR, Dr. Joyce Sitanik, head of clinical operations at AAR, and of course, Ezekiel Libamira, who is a throat cancer conqueror. Thank you for your time and having such a very important conversation with us around lifestyle diseases. Well, that's where we put a full stop to NTV Today. But do remember that AAR is officially opening their 21st outpatient center here in Lavington, to be specific, at the Westfield Mall. Well, that ceremony is coming live to you in a few minutes, so do stay with us even as healthcare is brought closer to you. Thank you for joining us on NTV Today. My name is Gladys Gashanja.